So it's obviously a great pleasure for me to be here, and I would like to thank Dr. Krishnan and the team for the invitation. These are my disclosures. Now, vessel prep, I think everyone is pretty familiar with. This is a technique that became popular with the introduction of the drug-coated balloons, and immediately after, we realized that also we can prepare the lesion, we can prepare the vessel not only for the drug-coated balloon, but also for drug-eluting stents. And from that point, we realized that there are a lot of advantages when we create a nice lesion. We can reduce the rate of dissection, we can reduce the number of stents, and obviously these advantages are more evident in complex settings. What does it mean? When you have an instant restenosis, or if you have a heavy calcified lesions, and when there is a chronic total occlusion. There are a couple of elements that we have to keep in mind. This correlated to the clinical evidence and the clinical experience. Unfortunately, we have some data regarding vessel prep, but there are not so strong level of evidence. We know that there are some advantages when we combine, for example, atherectomy debulking plus a DCB. We have a better patency rate, less restenotic rate, but there are not a clear level of evidence. So to define if the vessel prep is something useful for our patients or for our daily activity, we have to start to think about the clinical experience. So what we do generally in our lab, what is our practice, and how are our patients coming back to us. Now, regarding how to make a good vessel prep, we have to think about two different options. The first one is that we can debulk the lesion, so we can remove partially the calcium, and this can be done using the atherectomy or using a laser. Or we can modify the plaque, and then we have several devices like squatting balloons, cutting balloons, special balloons, lithotripsy, and other devices. So together, let's have a look to define when to use and where. Debulking, I think you are more expert than me, that's for sure, and this is especially because, the reimbursement in US is much, much better than Europe, and definitely of Italy, where there is not a reimbursement. For this reason, we are using debulking atherectomy just in selected cases, and this is when we have a 360 circumferential distribution of heavy calcified lesion, when the calcium is superficial and deep, so this means in the media and in the intima, and in instant restenosis. We generally prefer to use in short lesions because, if you have a long lesion, maybe this will be time consuming. The drawbacks, again, the economical evaluation, because we have also to combine some filters, and then we have to complete the treatment with a drug-eluting balloon, so this increases the cost, and obviously this is the reason why we are not using very frequently. However, we have a lot of good data, and I'll just show you and share with you this case. This was a nice guy that came with a short occlusion in the pop segment. This is, what we consider a no stent zone. Reason why, also with the presence of calcification, we use, the atherectomy device, and this was the very nice outcome that was then treated with a DCB. And very important, we have a 5-year and 10 years follow-up. You can see a very beautiful vessel, no intima restenosis, so patient is doing very well. So this is something that we consider a very nice vessel prep and a nice combined treatment. What about IVL? This is a new technology. It's a little bit different from atherectomy because we are not debulking the lesion. Calcium is over there. We are just creating some fracture, some channels within the plaque, and this allows the drug to navigate through and penetrate down to the muscle cell. We can use the IVL for intima and media calcification. We prefer to use in short lesions because we know that if there is a limitation, a technical limitation in the length of the balloon, but also again, no reimbursement in Europe, and also there is not a defined treatment algorithm. We don't know how many times we have to shock a lesion, 2 times, 3 times, we have to shock more. This is related to the thickness of the calcium. So there are a lot of question marks still open to discuss. This is a very interesting imaging, that where you can see that IVL is working not only in the intima, but also when we have calcification in the media, and nicely you can see here the microfracture that are also clearly evident on the IVUS. You can create a channel, and we know that this channel is enough for the drug to work and preserve the patency of the vessel. This is confirmed by some data. This is the primary patency reported by a couple of weeks ago, month ago by Gunnar Taper. You can see the great advantage when you combine IVL plus DCB versus standard angioplasty. What about scoring balloon? There are several out of the market which are used when there is also not a completely circumferential distribution of calcium or bilateral. We prefer to use for intima calcification, but we can use for either short or long lesions. The good thing is that we can save money. This is the reason why we are using pretty frequently, but sometimes we are not able to see the fracture within the plaque. So we are just to look on the results. Same story for what I can call special balloons, but these are defined in minimum trauma balloon catheters. Generally, we prefer again for intima, short, long lesions, but also for multiple lesions. If you have to work in the proximal, distal, SFA, POP segment, this is fine. And again, we can create some micro channels, in the plaque. Let me show you a case. It was a nice lady that came with a medial length occlusion of the SFA with a lot amount of calcium. You can see here without subtraction. We classify 4A, sorry. That means a bilateral 360 degrees. And we use the enforced balloon in this condition, the balloon with some peaks on the surface. And after that, what I would like to underline, you see, we inflate the balloon with a very low atmosphere, just 4. There's no more waste on the balloon surface, and then we treat it with a drug-eluting stent, because when there is a lot of calcium, the scaffolding, in my opinion, is still something very important to have a long patency rate, and this is the IVUS with a very nice apposition of the stent on the arterial wall, and then the 2 years follow-up. Another option is the Serenator. This is a new generation scoring balloon or special balloon with a dedicated or a specific structure. Also, this balloon can give us the possibility to use a very low atmosphere. So we reduce the stress on the arterial wall. Great results in terms of luminal gain, reduction of dissection, reduction of reintervention, and also this create a very nice numbers of microchannels within the plaque, so the drug can be penetrate and increase the patency rate of the patient. This is very beautiful images. You can see before and after using the IVUS. The channel is very clearly evident, as well as on a OCT image. Just to define, that I understand better what to use and when. This is what I'm doing in my cath lab. We can divide the lesions in what I can consider de novo is, medium level calcification, instant restenosis, and heavy calcified lesions. For the simple one, we can also use a simple dilatation, a simple balloon, piece of cake, and if it is working very well, we can move forward for a DCB. Instant restenosis, Tosaka 1, the simple one, simple PTA is fine. It is Tosaka 2 and 3. We use something more complicated, so debulking or laser or photoablation, and after that, DCB. What about heavy calcified lesions? My selection is more for plaque scoring, but also atherectomy is an option. And if I achieve, less than 50% residual stenosis, we can move for the DCB. After, if not, we can debulk the lesion with a more aggressive strategy. After DCB, if we have less than 40% residual stenosis and no flow limiting dissection, we are happy, patient back, we achieve our target. If not, we can perform a post-deal, keep a standard balloon for a longer period. If it's not working, spot stenting is the final goal. So in conclusion, we can affirm that vessel prep has become more and more popular. I can say now it's a must. Either if you're using, a balloon or you use a drug eluting stent, there are several devices available. What you have to select according, to your experience, reimbursement, and what is more familiar with you. Thank you for your attention.